Dr. Erin Lommen is a licensed naturopathic physician and is enjoying her 19th year of clinical family practice and health optimization through anti-aging practices. She was a clinical investigator for a successful 5-year study through the National Institute of Health on Chronic Disease. Dr. Lommen has taught as an associate professor at the National College of Naturopathic Medicine for 10 years. She is the co-author of the book Slim, Sane, and Sexy, Pocket Guide to Natural Bioidentical Hormone Balancing. And I've read that book. It's excellent. Passed it on to my doctor. They are available out at their at Labrix, Dr. Lommen, the book. It will be available at Labrix booth during the break. But we are very proud to welcome Dr. Erin Lommen.
Thank you. Does anybody have tired patients? How about fat patients? All right, so you're gonna hear some things today, a little bit tongue-in-cheek, but we actually, when we did the NIH study, the folks that we studied were the people coming through our doors. At least, I would say, 75% of my practice is filled with these people. The usual care arm was Kaiser Permanente, and I did the naturopathic arm in this NIH study. We started that about 10 years ago. It was ongoing for 5, but what I wanted to say was that the slang for this group of people was the fat chart syndrome. And in the managed care field, they're desperately looking for ways to stop the ongoing high maintenance, high utilization of care that these folks end up needing. And the good news was that our arm, no surprise to all of you here, performed the best of the 3 arms in the study, and we did basic functional medicine. And Kali said the word anti-aging, we're hearing the word functional, and honestly 25 years ago when I began naturopathic medical school, neither of those words were being used, and it was really naturopathic medicine that was about talking about physiology and function and correcting some of those causes and inherent disruptions and watching the whole body heal. If you're concerned about how you're going to integrate all of this that you're hearing here, the good news is that the body is programmed to heal itself. And we can go in and we can address adrenals, or we could go in and address the gut. We can do all of it at once. But even if you just took one of the triad that's being mentioned here today, I talk about it as likened to a 3-legged stool, where you, in terms of having your adrenal endocrine function, you have your gut detox function. Treating those, either one of them, you should have at least 50% improvement in your patients. And from there you can keep building on many of the therapies that we're talking about here. So I feel like joining the profession that I did was made very easy for me because the body was always working to help me do my job. 20 years ago I was terrified in terms of how to do this, how to incorporate all the things that we had to do. As naturopathic physicians, we have to study all the allopathic anatomy and science, as well as all the alternative therapies. And I can tell you, it took a good while not to feel overwhelmed when I got into practice. So we're going to talk about some things, and I overachieved, I have to admit. I think I gave you 90 slides, so that may be the record for your 45-minute talk. I'm going to go somewhat quickly, but try to touch on some clinical pearls that would be meaningful to you when you get back to your practices. And a few of the things is understanding when we talk about adrenal function and testing, that even though all those patients coming through look somewhat alike, you don't treat them exactly the same way, right? We both have the individual differences that have been talked about a lot in terms of why we take the time, why we spend that half an hour or hour taking that clinical history. But also, even within these systems, there are ways to tease out differences that make a big difference in how you treat. And so I'm going to try to elaborate on that. And then the second half of what I'm going to say pertains to insulin resistance, to metabolic syndrome, and this thing that we call PCOS. Frankly, I think it won't be long now before the term PCOS is going to start to shift, because our understanding has outrun what that terminology means. And I'll talk a little bit more about that in a moment. So times have changed. I think we can all agree about that. And we have changed. And I have the advantage of having seen thousands of adrenal panels on patients. And if, for example, we look at a 75-year-old woman and a 25-year-old woman next to each other, if I were to ask you which one you thought would be the most robust adrenally, who would have guessed the 75-year-old? That's what we're seeing repeatedly. Those 75-year-old gals look far better on paper and probably present quite a bit differently than our 25-year-old gals. There are a lot of reasons for that. I don't want to oversimplify today, but I do want to wake us up to this reality that we're seeing. That flat line in terms of cortisol pattern that's supposed to be a diurnal rhythm, high in the morning, low at night, is very flattened out, but it's flattened out by 25, 30 years of age. So what happened? In the 1960s, believe it or not, colleges had created programs called leisure studies. Seriously, the thinking was that with the advent of all the electrical appliances and automation in our daily lives, we were going to have so much free time that we would have to have practitioners and professionals tell us how to use this free time. Leisure studies, you could get a bachelor's degree at some of the colleges back in the 60s. Well, guess what happened? Instead of having so much free time and learning how to be peaceful, content individuals, we got busier. And we started to expect things faster and faster. We started to do more and more. And in fact, workers in the United States put in more hours than workers in any other country in the industrialized US. The sad truth is, though, that we are the least productive when we are compared head to head with those folks in other countries. So yes, we're putting in more hours, but our productivity is really falling off. And I think that we can talk about several aspects to how that's happening, but stress is certainly a very large issue for the US population. I'm going to talk more about what stress means as well, because stress can mean different things to different people, can it? And really, I think after hearing many of the talks, you already understand stress is as much an inside job, right? We're not really talking about, although you do interview and you want to know what's happening in someone's life, but you also realize that you can have two people with the very same things going on, and why is one, deteriorating before that kind of challenge and the other seems to be quite robust? So what is stress? It's when the sum of the physical and mental responses it's the disparity between our expectations and our experiences, essentially. Whether imagined or real, if there's a large disparity between what we're expecting and what we're experiencing, we're going to experience stress. Here's a little guy praying, God bless mom and dad, grant them the power to anticipate my every need and the means to fulfill them. We've got some big people walking around hoping for that as well, I think. So how does adrenal dysfunction present in your practice? As people are coming through the door, it's pretty much your list of chronic disease folks. You're seeing fatigue, insomnia, depression, headaches, nervousness, anxiety, the myriad of things that we're all accustomed to hearing. Some of the symptoms also have some similar things in that it's classic to hear someone say, I cannot sleep at night. Every night I am exhausted, I fall into bed, no sleep, and yet they wake up in the evening, right? They've gotten home, they may plop on the couch. I hear stories that microwave popcorn is the dinner of choice because they just don't have the energy. Lay down, turn on the TV, and then about 9 or 10 o'clock they start to pick up. And that's a real problem. Then they've got those few hours and then there's no sleep cycle, there's no REM sleep occurring. You can read through some of those other things, but those are the things that my patients are telling me as a result of their adrenal fatigue. So they kind of all look alike, but we do need to do some testing. I've been testing adrenal function with the salivary testing for at least 15 of the 20 years I've practiced. And I have to say that that's a foundation for how I treat everyone that comes through the door. Chronic disease states. Food allergy testing and this test would cover most of the bases in terms of building a really strong foundation. And so I do both on virtually everyone. So how are we going to test cortisols and DHEA? Those are really the hormones we're talking about. You have 3 fluids to choose from, and I'm going to quickly go through. I believe Dr. Mead later will talk about more science behind why saliva is becoming the gold standard for some of these areas. But saliva gives us those free hormone levels. For cortisol, in particular, we want to see the diurnal rhythm. So we want to see 4 times at least throughout the day. Some studies are even doing 6 times throughout the day. But that rhythm is very, very important to assess, and that's part of what these phases I'm going to get to are based on in terms of how that rhythm is stacking up against what we consider normal. Here's a bibliography of some of the validation of saliva testing for adrenal function testing. 1983, it was pretty clear in the first journal article there that cortisol was the way to test, saliva was the way to test for diurnal cortisol. Incidentally, when I did the NIH study, because Kaiser was doing the usual care arm, and they had all their serum testing available to me, they suggested that we not spend part of our $5 million on salivary testing, finding a lab that would do that for us, but let's use serum testing. And I emphatically stressed and had to go through the science behind both why I needed it, and also if we were going to study naturopathic and alternative care, that this was an essential part of how I evaluated and monitored my therapies. That was, as I said, over 10 years ago that we did that study. Kaiser Permanente in Portland, where I'm from, now does cortisol testing through saliva. So I have a little bit of a good feeling about that. So salivary adrenal function testing requires 4 cortisols and a DHEA test. That's how you get your adrenal function. And I want to note that DHEAS is not found in equilibrium in the saliva. So if you're using a salivary lab that's testing DHEAS, you're not getting your free fraction hormone. Remember, DHEAS is the sulfate form and more of a stored form. And when we're doing this adrenal function testing, we want to look at function. We want to look at physiologic levels day to day. So be sure that you test DHEA. Another note that's become clear looking at about the last 40 or 50 years of literature is that there's some variation in what you hear as to when that morning cortisol should be taken, that first tube that you spit in for your adrenal function testing. And probably within that first hour you're going to see a curve, you're getting useful results clinically. However, it's very clear in the literature that if you can hit it right at 30 minutes, you will see your cortisol awakening response. That is the peak. That is the most robust cortisol response there is. By 15 minutes before or after the awakening, it's already come down. And after an hour, you're back down at baseline, and you're not really going to see a diurnal cortisol. So if your patient calls you and says, oh, I've forgotten, it was about an hour and a half after I got up, should I still do it? The answer is no. Wait till tomorrow. Because the morning cortisol is the most crucial in your whole cortisol evaluation. That's, if one of them counts more than the others, this is it. So anyway, 30 minutes is what we're shooting for, and I try to remind people when I hand them the kit so that that's not confused later. So a reminder, the adrenal glands are a primitive regulatory gland, and I say that because it's just trying to figure out, am I safe or am I in danger? And I mean it from the standpoint of that hypervigilance that's been talked about, that's been alluded to. We have people who are stuck on high in that hypervigilance as a result of feeling very unsafe, as a result of being very fear-based, as a result of their PTSD. That's why those studies are coming out that very clearly equate PTSD with this flatline cortisol that I'm going to get to in a moment. What happens, even from early childhood, if there's a severe trauma, the brain is trying to memorize the situation and also protect us for the future. And it's saying, well, I've got to figure this out well enough so it doesn't happen again. And what it does is that the receptors in the adrenals become oversensitized to ACTH. And Dr. Lavelle alluded to kind of a downstream effect of that this morning, and that is that you secrete way more cortisol over just a small stimulus. So you're hypersensitized that way as well. So cortisol has 2 modes of operation. It's both proactive. in balancing us and doing things that we're not even aware of in terms of the sleep-wake cycle, food intake regulation, blood sugar regulation, things like attention, memory, integration of sensory information, what am I paying attention to, what am I ignoring, those kinds of things. And then it is also capable of regulating and initiating a reactive mode. And it facilitates our ability to cope during high times of stress through heightened learning and heightened memory. So a reiteration, reminding why it's so crucial to be understanding adrenal function and what's happened when someone's got adrenal dysfunction. Glucose metabolism, immune function, the inflammatory response, which is being talked about quite a bit, insulin release. The second half I'm going to talk very specifically about that, but these two are intertwined. You can't really address one without the other. There isn't anyone that's got insulin resistance that isn't in trouble adrenally, and vice versa. We've already talked a little bit, I saw an earlier slide similar, but in terms of this hypothalamus connection to the adrenals, it's enough to remember that we have this axis of communication. And that's being affected by stressors, by what's happening in our daily lives. A reminder of the adrenals, they sit on top of the kidneys, and they are tiny little guys, about the size of walnuts, and regulating virtually hundreds of things in waking day activity. The zones of the cortex, mainly what we're talking about today, are the zona fasciculata and the zona reticularis. Those are the secretors of your cortisol and your DHEA. It's significant to know a little bit about those, just because sometimes we buy into a mythology, or as we practice over the years, we start to believe something, and then we stop and say, where did I learn that? And one of the myths that I became part of 15 plus years ago as I did my adrenal work was that I somehow was told and believed that the zona fasciculata and the reticularis communicated with each other. So that if I had low cortisol, then that was somehow pulling my DHEA down, and that would become low too, and vice versa, as if there were a direct feedback loop right there in the adrenals. There is not. They are very separate compartments. And I believe that's because they're this primitive gland, they're a survival-based gland, and when one compartment of function goes down, the other does not need to. And they have some very separate, distinct functions, while they're also enhancing and cooperating in some of the function. So anyway, that's clarifying one myth. If you remember something today, it's that low cortisol does not mean eventually you get low DHEA, and low DHEA will not pull cortisol down through regulation in the adrenals. I threw this in here because remembering what the zona fasciculata is, not to be confused with the zona fasciculatae. That's your morning waking day hormone. That cortisol being secreted in that high amount is what gets you up and going. So what are some of the phases? These are what I've come up with in terms of talking about distinguishing between what can be happening and where we are in a spectrum of adrenal fatigue. Fight or flight would be an acute situation. Zigzag patterns, I'll talk about a little bit, the HPA axis. And then there are several phases of what we call adrenal fatigue and how those look. I want to remind us that DHEA is different than cortisol also from the time of birth. Within the first 3 months, DHEA production ceases. So all our little people running around are not producing DHEA. They don't have that zona reticularis zone is actually dormant. It's just gotten quiet, and it's going to wait till a year or two pre-puberty before it kicks back in again. So those stages of adrenal development regarding DHEA, you have the fetal adrenal, and that's producing many more times of DHEA. When the baby's in the womb, the DHEA is actually what's being converted to estrogens and some other hormones to sustain the pregnancy. Then once the baby's born, we don't have any DHEA being secreted. And then it's called adrenarche. It's about a year or 2 or 3 before puberty, DHEA kicks in. And you see the pre-phases where you'll see some growth in height and some of the other things, and then the gonads kick in by virtue of having that DHEA there. So I think I've gone through that. Incidentally, that said 200 times the amount of DHEA secreted by that fetus during that time. So it's a huge part of sustaining pregnancy, and then we go on to to no production once the baby's born. So that's just another look at this DHEA production. Remember, it's very important to understand this because you would never treat a child with DHEA. There are good reasons for why it's not there, and we don't interrupt with nature in terms of bone growth and fusion of the bone and cessation of bone growth, which would happen if we did treat with DHEA. So DHEA is also a stress hormone. It's been shown to help us a lot during those acute times of stress. And again, memory and mood are a big part of what it's helping us with. And it's helping us to discern what should I respond to and what shouldn't I. So those are the phases again. So in acute fight or flight, as we know, there's heightened activity at several levels. I remember being young and, hearing of mothers lifting cars off their babies or, those kinds of things. And where did all that tremendous strength come from that person doesn't normally have? And obviously, chemically, we can initiate certain responses as a result of this fight or flight. It's a quick burst of energy. Obviously, it's programmed for survival. That memory, you're hearing me say it in several capacities. It's important to know the brain is that set on trying to protect us for future events that look the same. Right? It's trying to keep us from having to go through it again if it's a really stressful, traumatic, or threatening situation. Here's a bird in its therapist's office with the broken wing, it looks like. And it was the classic fight or flight response. The therapist says, next time, try flight. So there's the healthy diurnal cortisol. Mainly, you're remembering you want to see a nice high peak in the morning, and it's supposed to fall off for the rest of the day so that it's quite low in the evening. Incidentally, if it's not, that disrupts the sleep pattern. Cortisol and melatonin are in a dance, and if cortisol does not go down at night, melatonin does not come up. And that's also a precursor to higher risk for breast cancer and some other things. So we want to see that healthy diurnal curve. Here's a quick look at an actual test result. If you see the results here, that's an acute fight or flight, very high rhythm in terms of the pattern we're seeing there. It's not often you're going to test your patients in that state, but that would be what it looked like if you did. Here's the HPA axis that I'm talking about, wherein it's the opposite of what we'd hope to see. Very low in the morning and really high at night. If we reverse that, we see that the gland is quite robust, but it's the opposite of what we want to see. Phase 4, or that beginning, what we call adrenal fatigue, starts when we start to see a high. We're still seeing heightened response. There's stress and there's trauma. It's too much. We want to see the cortisols in this. If you can see the green zone there, right around there. But then it's fallen way off. We've got both extremes, and that's early adrenal fatigue. Kind of another phase of evolving adrenal fatigue. And then we get to what we call the flatliner. Someone mentioned earlier that, and it might have been Dr. Harsh right before me, how latent tissue can be there, and it can be dormant, and all of a sudden here it starts regenerating, or there it starts doing something. Adrenals are, for the most part in our functional work, ready to rejuvenate. And I was told when I was trained to do this functional work that it would take 6 months to 2 years to get an adrenal gland back to optimal function when you treat it. I have a chronic fatigue patient who has seen me for many years, and we kind of gave up on her because it was 5-6 years in, and she was still on her cortisol support therapy. And that's not what we expect for most people. Even if we prime the pump with a little cortisol therapy, we get people off that. That's not a long-term solution. I'll come to that later, but it's physiologic dosing, so we're not running into the negative side effects that you hear about with steroid therapies in the mainstream. But anyway, 7-8 years down the road, we saw these adrenals pop back. And I had never been told that could happen. It did. And so I quit giving up on these chronic cases and every so often we would check off therapy. We continued to do right things, and she's feeling very well. So what happens? We're talking about the higher prolonged levels of cortisol in the bloodstream. We're talking about its connection shortly when we get to the insulin resistance part. But with chronic hypersecretion of cortisol, it ultimately leads to many disease processes that we've talked about, that inflammatory, that pro-inflammatory disposition that creates the terrain for many of the chronic illnesses. And eventually we see very little cortisol being secreted. People feel lousy. You know, when I ask them on the energy scale, 1 to 10, 10 is best, what's your energy day to day? These folks are, you know, they want to say 0, but I make them give me a number some of the time, and they say, okay, 1 or 2. But they're really pressed to feel like they've got anything going. So what are we going to do? I'm going to come back around to some more of this. But in terms of treating, this is treatable. And many of the things that have been talked about today are important to remember. I have distilled this down into some really specific things that you're going to do as you test and monitor people. So I'm giving you specifics, but this is not, you know, the full picture. Certainly addressing the mind-body connection and stress in general makes a difference. What I would say, though, is you have to take the time to hear in your patient, each individual, how do they access their motivation to change? Because we can hand people lists of things that would be good for them till we're blue in the face, and that doesn't help people change. What helps them is that we listen to them and we try to understand what's going to work for this individual patient. That's a general list of some things that can help. Here's a lifestyle list. You see laughing, belly breathing. I have everybody belly breathe. I don't say go take yoga or a very specific thing, but many of those things would help. But all of the relaxation techniques are based on breathing, aren't they? There isn't one that you could name that doesn't require that people get back into that diaphragmatic breathing. And most people are on autopilot. They're breathing very shallowly. And there are studies that show that cortisol curves return within 3 to 6 months in many individuals who just learn how to belly breathe. How do we teach that? I have patients lay down on the floor because it automatically forces them to start belly breathing. And then I say, let's memorize that. And now practice that. Do that 4 or 5 times a day for 5 minutes. Here's some of the phasing. You'll have this in your notes in terms of how to treat your test results. Vitamins B5, B6, you know, multivitamin, multimineral, you're going to see on all of these. Those are considered precursors and part of the foundation for treating. And then you get into some specifics that actually help the particulars of the cortisol pattern that you're seeing. Did I go too fast here? So I want to make a point on phosphorylated serine because you'll hear of it, you'll see it on adrenal lists, and it is only used when cortisols are high. You don't ever give that when cortisols are low. That's an amino acid that crosses the blood-brain barrier, and it will help lower cortisols. It helps the HPA messaging so that it quiets down during certain times of the day. And sometimes after you've treated HPA, then you see your flatline adrenal fatigue. But first you have to quiet down that HPA axis disruption. So the early adrenal fatigue, I'm going to bring in at times, and it'll depend. There are adaptogens and herbs that I bring in. If I see that the adrenals have a robust responsiveness, but it's the wrong time or it's too much, your rhodiola, your ginseng, your astragalus, those things are very effective. When we see flatline adrenal curves, you're not going to see much movement with the adaptogens at that point. That's when we have to bring in, I believe, it took me a while. I was a conservative naturopathic physician practicing for years before I started using the cortisol therapies to prime adrenals to come back. So the evolving adrenal fatigue, it's getting more severe as we go, and then that phase 6 is when we see the flat line. And your basic protocol is to treat with your cortisol therapy morning and noon. You're trying to hit that diurnal curve that we've already talked about and mimic it. You don't want to see high cortisols late in the day. Patients will call and say, oh, I forgot to take my cortisol. Can I take it? And it's 4 p.m. And we say, no. Don't confuse the body. We're trying to reteach the brain to regulate well. Some of the functional diagnostic clues that some folks use that you'll hear of, you can do a blood pressure test described there. Pupil dilation is another sign. You'll even have people that are tender and it's not kidney infection. It can be due to adrenals. So how long does it take? I alluded to this. And I put those little puppies there because you're always looking for ways to help patients understand what they're up against and what you're doing. I liken the adrenal glands to these little puppies because your adrenals want to do whatever you're telling them to do. Whatever your life is telling them to do, they're trying to do. And they're trying to do it well, and they're trying to adapt without you even realizing it. And so it's a slow process to bring them back as well. You have to convince your adrenal function by virtue of changing some of the things in your life that it's really okay to recalibrate. They calibrate down to that flat line because you were hyper-secreting and you were going to run out. And now you have to come back to a more peaceful place where the adrenals become convinced it's okay to come back. Anyway, depending on the phase that you find your patients in, the flatliners take longer to bring back. In terms of, maybe that's obvious, but that would be of note. I would expect 9 months to 2 years, as I said, on my adrenal protocols to see recovery and to see it corrected. Now, within 2 to 3 weeks, my patients say, I feel so much better. But we're propping them up with a bunch of things. My point is we can correct the dysfunction and get them back to not needing those props eventually. But the props get people feeling well within a couple weeks. And that's huge. Their energy levels usually, if they were a 1 or 2 when they came in, and we've got them on a protocol, within 3 weeks I want to hear that they're at a 4 at least. Some people are at 6, 7 very quickly. But you've got to hear that improvement or something's not taking. All right, so let's go through some thoughts on insulin resistance. Frankly, I don't think this would get nearly the attention if it didn't cause the belly flat. I really don't. The heart disease issue has been around a very long time, but it's getting a lot of press, and certainly the women coming through my doors are really frustrated because not only are they getting bellies that they never used to have, but their bellies are much harder to lose. They can lose weight in some of these other places, but they're having trouble getting rid of this particular type of fat. So when I say insulin resistance, what's the big deal? It appears this is the big deal in terms of what is going to get people through your doors and what you have to be equipped to help them address. You heard quite a bit about this today, but we're all concerned about the fact that children are predicted not to live as long as their parents currently, and it's as a result of the influences and diet in particular. I think Dr. Mead's going to present this as well on andropause in a little while, but this was just recently released in 2008, that fat belly is as strong a predictor of mortality as many of the other parameters that we've been using for years. So what's the incidence of insulin resistance? How common is it? 25 to 30% of the population, I think this is a 2004 estimate, and honestly it's a little conservative. So why is this weight easy to gain and harder to lose? That would take up a whole nother topic in terms of if we went into detail, but you can look up, and I put the reference there, neuropeptide Y. Mayo Clinic as well as these folks in London have identified one of the areas that might even lead to understanding better why some people are very, very prone to insulin resistance, and some may be a little more robust in avoiding it. Are hormones involved in insulin resistance? I think you already know. Indeed they are, but it's hard to say where one system stops and the other begins. You have to start to treat that whole person. And not only is insulin resolved, but glucagon, testosterone, growth hormone, thyroid, epinephrine, estrogen, cortisols, in terms of the situation. First, the liver becomes resistant in terms of not uptaking glucose normally. Then the same thing happens to the muscles. Then it happens in the fat cells. And it's really that triad of cells that when we refer to insulin resistance, that's what we're talking about. There's some references if you want to look. So what is the function? It may be obvious, but I want to make clear that insulin resistance is a synonym for hyperinsulinemia most of the time. We talk about it, insulin helps the body utilize glucose. It's likened to the key that unlocks the door so that the glucose can get into the cell, and then once the glucose is in the cell, it's used for energy in general. So what's happening when insulin can't get, or insulin doesn't unlock that door, we might secrete more insulin, and we're certainly going to have higher blood sugars eventually. But it's the hyperinsulinemia, it's the high insulin running around with nowhere to go or going in the wrong places, which I'm going to talk about in a little bit, that is really causing a lot of symptom problems and the fat belly and many of the other things. It's hyperinsulinemia. It's an over-secretion of insulin that creates some of the problem. And then where does cortisol come in? I was saying to someone earlier, many patients see TV ads that tell them that they have too much cortisol and that's why they have the belly fat or the problem. And we're really downstream a little ways by the time we're talking about insulin resistance. There was a time where they had too much cortisol, but by the time they're experiencing insulin resistance, you're going to see low physiologic levels of cortisol and you're going to see high insulin. So it can mean that insulin is no longer doing its job efficiently, meaning that it's not unlocking the doors correctly, but it's also synonymous with hyperinsulinemia. And as long as the beta cells are still functional, they have plenty of insulin to secrete, they'll do that. But as we all know, you can wear those out, and they have a finite quantity in their ability to secrete insulin. Normally, we have 20,000 receptor sites or so per cell. The average overweight person can have as few as 5,000 receptors for insulin. What's really happening, it can be high glucose in the blood. I want to remind you, though, your fasting glucose is not a tell-all sign, and that's usually, many of my patients have normal glucoses, or even kind of low, nice ones. It's because they have high insulin. It's still working, and there's some other things you're going to need to do to discern what's really happening. As to cause, I think that's been talked about some different ways. It's not absolutely clear what the cause is. Some of it appears to be gene specific, but in some folks it's not, and we certainly know lifestyle impacts it. The good news, in all individuals, the things that we do can change it. Signs and symptoms of insulin resistance. Very similar to that adrenal fatigue signs and symptoms page that we just went through. One of the last ones there, the acantharis nigricans, very classic sign of insulin resistance in terms of the velvety darkened skin. You can see it under the axilla sometimes or around the nape of the neck. What's the laboratory for insulin resistance? I'll tell you what I generally do, but certainly the fasting glucose and fasting insulin would make sense to have there, but I'm warning you those won't necessarily be abnormal and you can still have this problem. The insulin glucose tolerance test. Somebody was talking about postprandial testing earlier today. I don't do that on every single patient, but it can be very meaningful to do it on some of them. And we can talk about how to decide that in a little bit. 25-hydroxy vitamin D, I added to that. There was a time when I was giving this talk where vitamin D wasn't such a given, everybody's on board now. But that just happened. And 3 years ago when I was talking about this, I had so much concern in the audience I quit giving doses on my vitamin D because people were very terrified that I was giving these thousands of IUs per day. At least in my community, the understanding has shifted very dramatically, and that both the 25-hydroxy vitamin D is being tested routinely, and the doses have gone up 10 times what they used to be as far as comfort zone for most physicians, which is good news. That's listed there as well because, as you already realize, vitamin D has a very steroid-like molecular structure. In fact, it could have easily been classified as a steroid hormone rather than a, quote, vitamin. So when talking about testing, thinking through what you're doing, what you're not doing, here's somebody that had already thought it through for us, but still let's do an x-ray just to be sure. Meaning we don't have to do everything under the sun if we have ruled out the important things and we know where we're headed. Here's a clinical research pitting vitamin D against metformin, which regulates blood sugar. And I'll get to the importance of metformin on another level in a moment. But look at that, higher vitamin D status, and this was only, I have to say, 1,332 IUs. I use 5,000 a day when I'm correcting deficiency. You can go up to 10,000 safely. With that said, 1,332 a day is kind of conservative, but that's what they gave these women. And their insulin sensitivity improved 60%. They're only expected to get about a 13% improvement on metformin. So anyway, when we're doing this laboratory, if you do the insulin glucose tolerance test or a postprandial testing, the parameters that we'd like you to be thinking about would be to expect fasting glucose. If it's higher than 99, you're in trouble. Fasting insulin higher than 20, or on 2-hour higher than 27. But I'm here to say now in the functional realm, we get even a little more conservative, and we're reading between the lines, right? We're not waiting for end organ disease. We want to be preventative. We want to look at this well before we're in trouble. And so here are the numbers from the literature, and many of us that have practiced using these numbers have proven out. Fasting glucose greater than 90, you can start to assume you've got some trouble. 75 to 80 is where the body likes to be. Fasting insulin greater than 10. A reduced fasting insulin, glucose to insulin ratio, if you do some math. And then this fourth one is one that I've used if I do the postprandial test. Here's where we see the hyperinsulinemia, and it's a functional response to eating. So you didn't see it on fasting insulin. They had a very normal fasting insulin, and then upon the challenge, 5 times greater level than their fasting level. That's a much too dramatic response in insulin for the body to handle well. Here's a clinical pearl that I only learned probably 8 to 10 years ago. High salivary DHEA signifies insulin resistance. No one told me that. We started to realize it, look at it. It is in the literature now. It's in the PCOS literature. It's a lot of places. The high androgens in women, the high testosterone, the high DHEA. If you see it on serum, you're certainly going to see it on saliva. But what's happening there is that insulin upregulates the production of these androgens in women. So not only now are they feeling lousy and crummy, that whole list of insulin resistance symptoms, but they've got too much testosterone and too much DHEA, and it's not a good thing. This isn't a thing where, oh, I feel better when you put a woman on physiologic doses of androgens. This is I've got hair growth and acne, and I feel irritable and angry all the time, and I've had it. And so it's a very important pre-marker. When we catch it on saliva, there's usually plenty of time in the young women to reverse and correct that. What's the incidence of diabetes? About 5.9% of the population. Again, I believe those stats are from 2004. I think they've already changed, which is sad, in the last nearly 5 years. So the effects of high insulin, I want to remind you that this high androgen issue is for women in particular. High insulin circulating actually binds receptors in the ovaries. It stimulates the thecal cells to produce more testosterone. Period. I mean, it just does that. It's very clear that it does. At the same time, it also stimulates the adrenals to secrete more DHEA, conversion to androstenedione and testosterone. So we have this upregulation of androgens that has been called PCOS historically, but it looks like it's an insulin resistance problem. Treatment in the current allopathic world understands that, in that metformin has now taken the place of spironolactone, which was traditionally used to just block the DHT activity. Women that had a lot of acne and hair growth got spironolactone, and that helped. Well, metformin helps even more because it helps insulin sensitivity and helps the blood sugar issues. So inflammation is obviously the outcome we don't like. Syndrome X is part of insulin resistance, but it's when we have the cardiovascular markers that accompany the things that I've just talked to you about in terms of insulin resistance. The hyperandrogenism that I'm talking about can be very subtle. DHEA is supposed to be 106 to 300 in women. There's a 327, and testosterone can go up to 50, and it's only at 59, and yet that's very useful clinically. That we started treating, and this woman felt much, much better, and we reversed some of the issues that she was having. Here's the criteria for diagnosing metabolic syndrome. Here's some of the testing. I think you've heard about some of it from other practitioners. Certainly the VAP is better than your lipid profile, and on down into some of the other tests that we might do. Here are some treatments. I'm not going to hand anybody a list of all the things I'm going to give you, but I'm going to pick out 1, 2, or 3 from each list depending on their presentation. I have to tell you, I do have a favorite. We probably all develop those as we go along. But this one is amazing when you have the high androgens and the insulin resistance in terms of treating. I might use that in saw palmetto. Saw palmetto blocks DHT, so the acne and the hair growth goes down. I only use that for 3 to 6 months. And then by then I've corrected through these other means, treating the adrenal fatigue and the fenugreek and some other things. And we even see periods return to normal. Fertility comes back in women who are struggling to get pregnant, those kinds of things. I imagine many of you read about or are using these things in your practices in terms of metabolic syndrome and how we can address that. Most of you probably know if you do use niacin, it's very effective. It's pretty inexpensive, but be careful. The only patient I've ever had in the 20 years of practice go to the emergency room following a therapy from me was someone who went home after my explaining the dose of niacin that we would be using, and she somehow hadn't heard me say, but you're going to start on 500 milligrams for the first week and then titrate up by 500 each week. She took 2,000 at once, and she took her other supplements that had quite a bit of niacin in it. And the good news was the ER doc knew what niacin was and what it did, and so that it didn't create too big of issues. Diets, we've certainly talked a lot about anti-inflammatory eating. That's essential for these people. We've got to get on the low glycemic index foods, and we've got to have them consuming complex carbs. I'm going to order a broiled skinless chicken breast, but I'd like you to bring me lasagna and garlic bread by mistake. So that's what we're up against, isn't it? In terms of the dietary work we do, you've got to access your patient's motivation. Where is their particular window in? Everybody's different. Our emotional relationship with food is unique to us, and so you just can't slam a page of dietary changes down without discussing with patients at length what it's going to mean, how are they going to do it, what foods will they eat instead, those kinds of things. That time is well spent. And I know I'm about out of time. We all know this, glycemic index, what it does to our blood sugar and how fast it creates symptoms. I speak on the gut as well, but people always want me to, as a naturopathic physician, to address what the best diet is ever. So here's a list that I was exposed to in school. Looks probably familiar to most of you. And honestly, there isn't a best diet, is there? There's test them for their IgG allergies, get them off the foods they're allergic to, and then get them anti-inflammatory. When I did the NIH study, one of the gals that I was treating cooked for her mother and cared for her mother full time, and she came in 3 weeks follow-up. I'd gotten her on the anti-inflammatory diet. We were doing many things, and she said, this is a population from Kaiser. They weren't really versed with doing dietary things at all. She said, well, this is going to sound really strange, but my mother, who's in a wheelchair, was up and walking in the garden. And her inflammation had so dramatically changed because this gal was cooking for her and had changed that inflammation. And so it definitely works. It makes a big difference. Skip over that. Bottom lines here, optimal health in this regard, balanced adrenals and lowered insulin. Remember that in our youth, when we had optimal growth hormone levels, which you're hearing a lot about all the time, when those were very high, our insulin levels were relatively low. I think that's it. Yes. Thank you.